Welcome to week 4 of Advocacy, Ethics, and Public Policy. The topic this week is Medicare. I'm going to be elaborating on your readings in two areas that have special impact for hospitals, health systems, and the physicians that you work with. The first area is the payment and delivery system reforms that are in the Affordable Care Act, now a key part of the Medicare program and the way it pays for both hospital care and physician care. Then I'll address some of the key advocacy issues that affect our health systems regarding the Medicare program. I'm going to close with the discussion question for this week, which relates to the payment and delivery system reforms that we'll cover at the beginning. Those reforms are rooted in this idea that the system needs to change from one that is focused on fee-for-service and, in effect, incentives for volume of care, rather than incentivizing value, that is, outcomes, cost-effectiveness, and coordination of care that can create better outcomes for patients, better health for populations, and lower per capita costs overall. You can see in this chart kind of the idea of a transition moving from the old siloed payment system to one where there are more incentives for coordinating care, for, in effect, reducing avoidable utilization in the system in a way that will still maintain or improve quality for the patients that are being served. We saw in week 2 that these delivery system reforms in the Affordable Care Act come under the auspices of the Center for Medicare and Medicaid Innovation, which received under the Affordable Care Act $1 billion over the course of 10 years to develop and test various models. Some of those models are involuntary and required by the hospitals and physicians that we work with, and then some are voluntary, as we'll talk about in a moment. Starting with the involuntary. You saw this slide earlier, but I want to review these various pay-for-performance programs for hospitals and physicians as of 2017. The hospital side applies to this year as well, but we will see in a moment that physicians started transitioning to a new pay-for-performance system after 2017. The chart shows that hospitals are at risk for a total of 8% of all Medicare reimbursements. This starts with the value-based purchasing program, whereby 2% of all hospital payments are withheld, and then the hospital earns back some or all of those payments by how well they perform on the indicators that you see on the right-hand side of the chart. If they perform especially well on these indicators, they can earn an additional 2% above the original 2% that was withheld. The Hospital Readmissions Reduction Program penalizes hospitals for up to 3% of all Medicare reimbursements based on whether their readmissions are inordinately high for 6 specific conditions. These would be conditions like heart attack, pneumonia. But again, the important piece here is that they are penalized for all Medicare, 3% of all Medicare reimbursements, not just for the 6 conditions. You'll see in your readings that there has been some controversy about the effectiveness of this program, but there seems to be agreement now that it has had a modest, at least a modest impact. The idea, of course, is to incentivize hospitals to manage patients more effectively when they're in the hospital, but more importantly, to manage transitions to care for post-acute care and care at home, and to ensure that post-acute providers are working with them to keep patients from coming back to the hospital for recurring conditions. The Hospital Acquired Conditions Program has been one of the more effective. Studies have shown that this incentive has actually contributed to a decline in hospital-acquired conditions. These are things like infections, bed sores, blood clots, hip fractures, falls. The hospital is penalized 1% if they are in the bottom quartile for these avoidable conditions. And these studies have shown that there's been about a 13% decline in these conditions over the last few years. for a savings of $17 million to the Medicare program per year. The Meaningful Use Program is a set of incentive payments and penalties designed to incentivize hospitals to make meaningful use of electronic health records, especially by improving interoperability. We'll talk more about this at the intensive. The physician side of these programs was in place up through 2017 and was similar to the hospital incentives, because the intent here was that there would be some integration of those incentives and incentives to collaborate. But the physicians have been transitioning over the last few years to a new program. That new program for physicians that started in 2017 is called the Quality Payment Program. Physicians have been transitioning since 2017, and as of this year, the program is largely in place. There have been some difficulties for physicians in making this transition, as we'll talk about at the intensive. This program was authorized by the Medicare Access and Chip Reauthorization Act, or MACRA. Sorry about that, but sometimes the titles of these laws are pretty long, but you'll see references to MACRA in your readings. MACRA replaced a program that had been in place for 13 years called the Sustainable Growth Rate Formula. This was legislation passed in the late 1990s in response to rapid growth in physician payment under the Medicare program. The formula was designed so that if overall growth in payments to physicians exceeded a certain target in any given year, then in the next year, physician payment rates for the individual physicians would be reduced. The program ended up in creating eventually what would have been large reductions in physician reimbursement, but year after year Congress would step in and postpone those cuts to the point where finally there was enough frustration around the way this formula was working that Congress did go ahead and replace it with something called the Quality Payment Program within the MACRA legislation. That sorts physicians into two groups. One, at the bottom of the slide we'll talk about in a moment, physicians that can set up alternative payment models that meet certain requirements and get an advantage over time in the reimbursement system. But the middle track for this program is the one that's more common for physicians, at least now. This program, called the Merit-Based Incentive Payment System, or MIPS, combined what had been three physician quality programs up until that point that you see listed here. The first thing that MACRA did, you can see in the top green row of this chart, which was to set increases in physician payment on a fixed basis starting in 2016 at 0.5%. So their payments would increase by that amount. That would go down to zero starting in 2020, and then when we get out to 2026, you can see it goes up to annual updates, and we'll see why there's a difference in a moment. The next thing that MACRA did was to create these two tracks, the orange one and the green one here, depending on which group physicians could qualify for. Most physicians at this point would be in the MIPS program, as we talked about. The yellow arrows that you see here were the programs in place up until 2019. This is the first year where we've really have fully transitioned. So in this year, physicians are at risk for 4% of their payment, but notice the plus or minus side. They can either lose as much as 4% of their payment or gain as much as an additional 4% of their payment, depending on how well they perform on the MIPS quality and patient satisfaction and efficiency indicators. And we'll talk about those in a moment. Notice that that amount goes up and eventually reaches 9%, so there could actually be a 9% swing in how much physicians are reimbursed depending on how well they do with this formula, gaining as much as 9% or losing as much as 9% in their reimbursement. The bottom row are the alternative payment models, if physicians can qualify, especially by taking financial risk for the treatment of patients in alternative models. They do not have to adhere to the MIPS measures, but instead will get a 5% incentive payment each year because they are deemed to be in a program that is designed explicitly to both be more efficient and higher quality for patients. So the amount of reward or penalty under the MIPS program in each year is based on these 4 indicators: quality, resource use, which in effect is the cost of services provided, clinical improvement activities, and then promoting interoperability with electronic health records. You can see the percentage that applies to each of these categories this year, as well as the fact that there is a shift around the cost issue in future years as that measure becomes more reliable over time, and if there's an increasing emphasis on the idea of making care efficient as well as quality driven. This slide shows the requirements for a physician group to be considered to be in an alternative payment model, that second track that is very beneficial because it entails 5% increases in payment each year. The most important requirement to be in an APM is that the physician group is facing downside risk as well as upside risk. So it needs to be a model like an accountable care organization or one of the other several models where not only are they rewarded on the upside for demonstrating savings and sustained quality, but also at risk if they don't demonstrate more efficiency and quality. They're at risk of losing some of their payment. And so that, along with the other requirements shown on this chart, is the way that a physician group would qualify as being in an APM. Next, we move to the voluntary programs, accountable care organizations, bundled payments, and medical homes. This slide demonstrates how much variation there is within each of these 3 programs, where CMMI is testing various approaches to see which ones work, because one of the things the Affordable Care Act did was authorize CMMI to go ahead and move some of these programs into a mandatory status if they can be proved to be effective. This slide is somewhat dated, but still very useful, as is the citation at the bottom, the Kaiser Family Foundation primer, which you may find useful as you work on your discussion question for this week. You can see here the variety of medical homes. You can also see that there's several types of accountable care organizations. Recall that this is a set of hospitals, physicians, long-term care, and other providers that have agreed to work together to try to lower the overall per capita cost of the Medicare beneficiaries that they're serving. CMS looks at what it is that was spent by them on each of the patients on an average basis, compares that to what otherwise would have been the case under Medicare, and if there are savings, then the amount can be split between the providers that are involved and the federal government. This is why it's sometimes called the shared savings program. The various providers in the ACO are still paid under traditional mechanisms. So the hospital is paid DRGs, the physicians are paid on a fee-for-service basis. But if overall savings are achieved, then the providers share in the benefits of that. The different tracks refer to the fact that some ACOs have upside potential only and are not at risk for downside. In other words, if they do achieve some savings, there is some sharing. But the programs that tend to be a little more effective, we think over the long run, is where downside risk is involved. The rewards are greater for cost savings, but there also is penalty if the overall per capita costs for beneficiaries within the ACO actually exceed what otherwise would have been the case. The bundled payment approach we talked about before is designed to try to solve the problem of individual specialists, hospitals, other kinds of providers and medical device companies all being paid separately for a particular procedure like a knee replacement.
which of course creates no incentive for the coordination and efficiency of care over the course of treatment. The bundled payment is designed so that a benchmark is set for how much that whole procedure should cost from the time of going into the hospital till 90 days after leaving the hospital. Create a single amount for that, and if the group does better than that benchmark amount, then they can benefit. The way that is put in place, though, is usually that the hospital is at risk. So the hospital is in a position to try to work with the physicians, post-acute providers, and others to better coordinate the care and bring down the cost while sustaining quality. And if there's success in doing that against the benchmark, then in effect there is a revenue gain for the providers that are involved. I'm going to turn now to the third dimension of our course framework and going through some of the current key advocacy issues that are important to the hospital systems and physicians. As we go through these advocacy issues, I want to start with the idea that some of them are affected by particular pieces of legislation considered or passed by Congress, or pieces of budget packages that are passed by Congress. But others are affected by the annual rule that CMS puts out each year on payment levels for hospitals and physicians. And we, as Catholic Healthcare, advocate in both of these areas. An example of one that is influenced by the rules each year is payment reform implementation. So all of these programs we've been talking about, such as the new physician payment program, entail a whole series of implementation issues that are important to us. MACRA and the new physician payment system is a good example because many of our physician partners have had trouble with implementing and transitioning to this new program. As a result, there's been advocacy, and as a result of the advocacy, CMS has sometimes changed the schedule and the requirements under that program. There are a set of rural payment issues that are important to Catholic healthcare. Critical access hospitals are sometimes challenged by some members of Congress, and there have been efforts to curtail the program, to radically modify the program that have been threatening to some of our organizations in rural areas. And many of our facilities benefit from rural payment programs that are designed to adjust Medicare payment to adapt for the low number of patients and the isolation that many rural hospitals face. So, for example, there is a high Medicare volume adjustment under Medicare that is designed for rural hospitals that have a lot of Medicare patients but not very many commercial patients to make up the difference in revenues that are needed by the low reimbursement rates of Medicare. These kinds of programs need to be extended on an annual basis, or sometimes we try to make them permanent, or sometimes we try to reduce counter incentives that are inherent in some of these programs. Telehealth is becoming more and more important as a way of reaching remote patients in rural areas or in other facilities. Increasing evidence that this is an effective way to serve patients, both cost effectively and in terms of quality, and there are legislative efforts being discussed around reducing disincentives for the use of telehealth and also enhancing reimbursement for its use. Stark and anti-kickback reforms refers to a law and a set of regulations that are designed to prevent inappropriate self-serving behavior between physicians and hospitals. So, for example, there would be a legal challenge under the Stark law if a hospital wanted to set up a special bonus arrangement with physicians in order to encourage the physician to refer their patients to their hospital. These are the kinds of levels of integrity that the Stark law seeks to maintain in terms of the patient interest coming first for both the physician and the hospitals. There's an increasing recognition, though, that some of these regulations can get in the way of delivery system reform. So, for example, if a hospital does want to be able to work with physicians on cutting costs and achieving clinical goals through some kind of joint payment arrangement, like you see in bundled payment or accountable care organizations, well, then these laws could get in the way of that. And there have been efforts and will continue to be efforts to make adjustments to, in effect, modernize the laws for the new world we're in, where we're trying to create new mutual incentives for more effective and higher quality and cost-effective care. Payment cuts are a significant issue for hospitals and have been over time, and will become increasingly so after the 2017 tax package, which increased the deficit and will be putting increasing pressure on Congress in the long run to find continued savings in the Medicare program. And of course, provider payments is usually the easy place to go for those kinds of savings. A particular proposal and set of new payment approaches that have been put in place today are called site-neutral proposals. This is where hospitals under the old system were paid more for outpatient care in their outpatient department than would be the case for a patient getting similar care in a physician's office or ambulatory care setting that is independent from the hospital. So CMS and Congress have both been moving toward making these payments equalized, which means reducing the amount that is paid for care in hospital outpatient departments. The hospital community has pushed back against these efforts, demonstrating that there are additional services that are provided within a hospital outpatient settings, such as standby emergency services and other standby services, and also a recent study that has shown that the types of patients served in hospital outpatient departments tend to be lower income, tend to have chronic conditions, and tend to have a history of having to get care in the emergency setting at the hospital. All of which adds up to the idea that either for the types of care provided or for the particular patients tended to be seen in hospital outpatient departments, there actually are higher costs involved. The importance of these cuts to payment to hospitals becomes starkly apparent when you look at the cumulative effect of Medicare payment reductions to hospitals between 2010 and 2028, beyond those that were already in the Affordable Care Act. You'll recall that built into the Affordable Care Act was this kind of bargain that hospitals would see reductions of around $158 billion over this 10-year period, with the recognition that hospitals would be seeing more reimbursement for newly insured patients as well as those that are covered through the Medicaid expansion. But beyond the ACA, there have over the years been a series of cuts implemented either by Congress or CMS that have put an increasing toll on the financial integrity of our facilities. An example here out of the $218 billion in cuts over this period between 2010 and 2028 is sequestration, which was a policy put in place several years ago when there was a budget package that was intended to reduce the deficit. The budget package had a trigger mechanism where if certain targets were not met, then automatic 2% cuts would be put in place annually for a certain set of programs, including provider payment, or at least hospital payment under the Medicare program.
Now, we saw last week that relief on some of these cuts is one of the ways that Congress has been dealing with the impact on hospitals of the coronavirus. Remember, we heard last week that sequestration has actually been suspended for the remainder of the year, and there has been relief on some of these other cuts as well.
Cumulative cuts begin to take their toll on hospitals, and this is why this becomes so important in terms of the advocacy work. The hospital Medicare margins have been in negative territory for over a decade now, and in recent years have continued to worsen. As you can see from this chart, this is certainly in part due to the various kinds of reductions in payment that have taken place in the program. Now, this is not to say that hospital margins overall have been coming down. This shows that all payer margins have been relatively stable in recent years, but it does mean that Medicare is carrying less and less of its share of the load, and means that in general hospitals need to try to find the difference in making up those costs from commercial insurers and others.
Now, returning for a moment to the full set of issues we've just discussed, the coronavirus, of course, has been having a significant impact on all of these issues and will shape the way they unfold and the way we will deal with them in the long run as well. We saw last week that payment reform requirements around reporting are being suspended. We saw that reimbursement for telehealth is being expanded. The Stark rule right now on this chart is under consideration to see if there's ways to loosen those requirements to take the pressure off of hospitals and physicians. And then the payment cuts are being relieved on a temporary basis, including things like sequestration as one of the ways to try to get new revenue into hospitals. At the same time, as much as our future will be different and as much as things are changing in real time, as you can see from your contemporary readings, there also will come a time when we come back to some of all of this, hopefully post-virus, such as the payment and delivery reforms that we discussed earlier. Some of those are likely to change, some will stay in place and be operating in a different environment. But it does mean we come back to some of that, and hence while the question I'm posing for discussion this week around delivery system reform may seem a little out of place for now, considering what we're all facing, it is still going to be an important question in the future, and I hope you'll all benefit from the assignment for this week.
So the question for this week will come from the first dimension of our class framework, where we'd like you to think about how it is that your organization responds to the policies that have been put out there around Medicare payment and delivery reform, including both in the hospital sector and in the physician sector, depending on the particular topic that you choose. And importantly, we'd like your discussion to focus in on how it is that our response strategically and operationally to these policies is informed by our ethical commitments, by Catholic social teaching, and our overall mission. So to do that, I'd like you to pick one of the Medicare payment reforms that we've been talking about, either in the Affordable Care Act or the MACRA reforms for physician payment. Pick a particular one, and then assume you are working with a public policy advocacy leader in your facility or system to develop a presentation for some of your leaders on what they need to know to prepare for or to improve their performance under one of these programs. So you could pick one that has not been put in place or one that is in place, but the leaders are looking for improvement. You can assume that the public policy leader will describe the program and the strategy considerations for the group, but your job is to highlight the benefits, opportunities, challenges, and potential pitfalls of the program from the perspective of our mission and ethical commitments. And what I'd like you to do is to describe what points you would integrate into that presentation. There is at least one optional resource online for you to investigate one of these payment reform mechanisms, and I think it in turn will lead you to other sources online if you need additional information about the programs themselves. Good luck with this, and we'll see you online. Thanks.